Thanks, everybody. If Jack Atkinson from Mosh, if anyone sees her in the hallway or peeking in, if they can just invite her to come join us, she can come join when she does. But appreciate everyone being here. So to get started, we just heard individual bios, but I was hoping each of you could speak a little bit about the organizations, programs that you work with, what kind of work you do, what kind of services you offer, and especially how you engage with clients or participants or patients, especially if they're not coming to you seeking addiction treatment, how you build those relationships and care for people.
As myself, as well as I would say the majority of people who work at Mainline are people with lived experience. And that's really a core thing with our work. It kind of makes that barrier of trust go a long way. I know for myself, when I lived on the streets, there's not many people you can trust. So having a place where people have actually been there kind of bridges that gap. So that's definitely one way. But really, all of our services are really focused on meeting the people where they're at, whether that's literally going to their home, whether that's meeting them at an encampment, whether that's, or more metaphorically meeting them where they're at. But I'll let somebody else speak.
Thanks so much, and thanks for the introduction, and thanks for CRISM organizers for bringing us together today. So Peers Alliance is, in fact, an acronym that stands for Prevent, Educate, Empower, Respect, and Support. So we are an organization that tries to live and work from our values. We offer various health promotion and harm reduction services to folks who are actively consuming substances, primarily delivered through outreach teams. So we have outreach staff who do street level outreach in the capital city of Prince Edward Island, which compared to Halifax is fairly small. So they would be doing like walkabouts or street level outreach, visiting folks wherever they're staying, working with community partners who may be offering shelter services or day programming. We also have a mobile outreach team that works to get out into the more rural communities in Prince Edward Island, often functioning sort of like that connecting piece to other services. So we would be offering navigation support, harm reduction materials, so safer consumption or sterile consumption equipment, drug testing services, both with test strip technology and more advanced drug checking services with FTIR. We also offer peer engagement and empowerment type programs in groups. It's community members who access harm reduction services that pack all our safer consumption kits. We also have folks coming together to chat about current challenges or trends in community and areas where they feel like as peers they can tackle some of the issues that are happening. So happy to chat about that more, but I'll pass the mic.
Okay, thank you very much. So really honored to be here today, and nice to share the panel with a fellow New Brunswicker as well. So among the hats that I wear, I do work at the St. John Regional Hospital, which to acknowledge that that is on Wolastoqey land, traditional and unceded territory of the Wolastoqey people, and honored to live, work, and play there. At the St. John Regional Hospital, I'll often see individuals in inpatient consultation. So a lot of times as an infectious diseases doc, I will be asked to see somebody who has an infection, and a lot of times it may be related to substance use. And so that's where it becomes part of the history taking, part of getting to know an individual, part of understanding their story. And it may or may not have relevance to why I'm seeing them. And whether it does or doesn't, it is something where we can engage people, meet them where they're at, and talk to them about options if relevant and if interested. Options for, it may be individuals who are admitted to hospital for, again, unrelated reasons, but they may have substance use and they may have needs that would be otherwise overlooked. So making sure that they have access to harm reduction supplies, making sure that they're comfortable, pain is well managed, those sorts of things. But inevitably, it is an opportunity to engage, and if it is something that people do want to have addressed, so as an example, if somebody is using opioids and they're nervous about the supply in the city, and they do want access to a safer supply, be it methadone, be it Suboxone, then it's an opportunity again to engage in care in that respect. And it becomes one piece of the overall thing. There's often an issue, I'll talk to people as well, about vaccination status, about safer use and mental health and other things, and help out as we can, because again, trying to provide that holistic care. Also, I work in a not-for-profit clinic in the community setting, which is unattached from the regional health authority. And sometimes it's good, because if I am meeting people in hospital and we want to provide good continuity of care and follow-up in the community, and it's an opportunity to say, well, on discharge, this could be part of your discharge plan. If you want to engage with us at the clinic is called Recap Clinic, then that gives us an opportunity there. So Recap Clinic actually came from a move to improve hepatitis C screening and management, but recognizing it's not just about hepatitis C. There are other bloodborne pathogens and STIs that we can also manage. But it was a way, as an infectious diseases physician, if I wanted to be involved in organizing what would traditionally fall under the Department of Addictions and Mental Health clinic, then I would be called out for duplication of services. But I can talk about hepatitis C safely. It's what the government pays me to do, and so I can talk about it. But again, in terms of holistic care, if I'm going to just address hepatitis C and not look at the person as a whole, or discuss some of the other factors that may promote infection, reinfection, or be a hindrance to optimal screening and treatment, then it only makes sense that becomes part of an overall management strategy. So on both of those levels, we're able to engage people. Sometimes people are coming to us directly saying, I'm struggling with substance use, and I do want to try to find some harm reduction strategies, opiate agonist therapy, that sort of thing. But a lot of times, it's not the primary reason, but it's something that falls in the wake of what we're trying to address at the front.
Thanks, Duncan. Before I ask another question, I just want to go back to Morty for a sec. You had talked about how important it is for people with lived experience in your organization, building those relationships and connecting with people. I was wondering if you just wanted to share, for folks who aren't familiar with Mainline, and perhaps the Friendship Center as well, what kind of range of services you offer, some of that, the direct care you're providing in the community.
Yeah, for sure. So Mainline is a project of the Mi'kmaq Native Friendship Center. It's the first needle exchange in Atlantic Canada. Started in 1992. Prior to that, there was the Persons with AIDS Coalition that started distributing needles, but people from that same group went on to found Mainline. Originally, our main thing was just getting out, needles, and then eventually that expands to other harm reduction supplies. Then that expands to other services. I mean, we do over 400 people a year's taxes, It's not necessarily a service you think of when you hear needle exchange, but, we have some people who only come to us for taxes. So we're very low barrier, almost actually. Well, there are some barriers, unfortunately, because, it's just the way it is. But we're very low barrier. Like, anybody who walks through the door can access our services, whether that's getting a snack, whether that's, peer support, whether that's taxes, whether that's information about safer injection, whether that's how do I properly pack this stem so I can smoke crack, I'm more than happy to show somebody how to properly do something. I know often people might assume that's a bad thing, but one example, a woman I know in a abusive relationship, the person she's with is the one who does the injecting. She doesn't know how to inject, so now she's stuck in that relationship with someone who does the injecting for her, and she doesn't know how to do that for herself. So having somebody show her how to inject, she can now leave an abusive relationship, and maybe that ends up saving her life right there, let alone preventing blood infections and endocarditis and all kinds of other stuff.
Awesome. Thanks, Morty. All of your teams and programs seem to provide quite a range of services for people with different needs in your community. And I'm wondering how, as organizations, you decide what you're going to offer, what's available that you're going to be able to provide to people, and whether there are barriers there that are preventing you from doing more, whether that's like resources or our political climate. How are you and your organizations navigating that?
We try very hard to be responsive to community needs, and so we're constantly engaged with participants in our programs around what services they're looking for, and where those services don't exist, is there a role that we can play in introducing those to the local service landscape. There, obviously challenges in that. Funding streams may not always reflect needs locally. So yesterday, for example, we were hearing about the emphasis on fentanyl or down and the toxicity in down street supply, but also aware that for a lot of communities and a lot of community members, it's stimulants that are issues. And so, that can become a challenge for folks in even generating funds needed to purchase safer smoking equipment, for example. We've been hearing from community members accessing our harm reduction services since pre-pandemic about the need for a supervised consumption service, primarily in Charlottetown, the capital city of Prince Edward Island. We had made some gains there, but changing political tides have prevented the introduction of that service. So that would be an example of sort of the politicization of public health, or in particular, the politicization of harm reduction services becomes a barrier to supporting people in meeting their needs. I had another barrier in my brain, another thought, and it might have just escaped. Maybe I should have had that other cup of coffee. Stigma, I think, was where I was going to go. So primarily folks who are accessing Peers Alliance harm reduction services are folks who may be experiencing other challenges. So folks who are housing insecure or homeless, folks who are experiencing challenges related to mental health, and some cross-pollination, I guess, between folks who are accessing queer health promotion programming who are also consuming substances that are introduced to our programming that way. There are so many more people in Prince Edward Island who are using drugs who would benefit from access to our harm reduction services, but the high degree of social surveillance locally, as well as the stigma attached to substance use, often prevents those folks from meaningfully engaging or even learning about what Peers Alliance is offering and how they may be able to use our services or the tools that we provide to promote their own health. So those would be a few things that come to mind immediately.
Thanks, Angele. Could you just say a bit more about what you mean by social surveillance in your landscape in PEI? Is that because it's a small community where everybody knows everybody's business kind of thing, or?
Yeah, that's what I'm referring to. Just because our province is so small and everyone kind of is one person removed from someone else, we see folks in rural communities just there's not a lot of trust there with service providers, or even with being open about the fact that there's someone who's consuming substances. So, as I think probably everybody in this room knows, harm reduction work is relationally based work. That is work that takes a significant amount of time to really engage with somebody, learn a little bit about their story, trying to understand what their own goals are and where they're motivated to make changes. Those type of interactions are really hard to have when you're talking about really brief interactions that are happening out of the window of a vehicle or when someone's walking through an encampment. So again, like something like an overdose prevention site where folks are actually invited into a service where they're not rushed out the door. That's the type of infrastructure that does support more meaningful harm reduction work in happening. But yes, everybody is someone's aunt, and so folks are super often skittish of accessing services particular to drug use.
Thanks very much. You guys have thoughts about that? I can remind you of the initial question about how your programs and teams decide or are able to provide the services you do to meet community need, and if there's barriers you're facing, resources or political, that prevent you from doing more or prevent you from addressing those priorities you'd want to otherwise.
I mean, funding's always a barrier when it comes to harm reduction in general, but general attitudes, you know, tend to affect everybody, right? Like, so internalized stigma is a big reason somebody might not want to come to Mainline, because for some people that can almost feel like you're admitting you have an addiction or something like that, right? And it's not that at all. You're just, you know, getting a service. But to some people, it feels that way. I mean, we have clients who don't even use drugs. But, you know, just going into a needle exchange can be a very daunting experience for a lot of people. So they might just rather buy needles, you know, and then end up running out of money and reusing them, right? You know, I knew one person who was just too proud to go to a needle exchange. This is prior to working at a needle exchange. It was like when I was living on the streets. But then he always ended up reusing and sharing because, you know, he was too proud to walk in. He's like, I don't want government funding, blah, 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 right? So, I mean, internalized stigma and things like that can be a huge barrier, and a lack of education within the community, you know, is a huge thing. And lack of funding to get that education out there, as well as, you know, elections and politicians who like using people as scapegoats so they can get votes, you know, that has some negative consequences for sure, right? Yeah, but I'd like typically as a team, we make most of our decisions. I don't know if that quite answers your question or not.
Yeah, no, appreciate that, Marty. Okay. Duncan, do you have thoughts on that one?
Sure.
Hi, Jack. Hi. Sorry. This is Jack. Sorry. Do you want to come on up? So we can loop you in, Jack, if you'd like.
Oh, dear.
Thanks for coming. I don't have the piece of paper.
No, don't.
But if you could introduce yourself, talk a little bit about what MOSH does, and the initial question, which is still relevant to where the conversation's at right now, is how you guys engage your clients or participants or patients, even if they're not coming to you seeking addiction treatment. But how do you build those relationships and provide care and services?
Okay. Well, probably first of all, I'm Jacqueline, one of the nurse practitioners with MOSH, a program at the North End Community Health Centre in Halifax here. But I just want to, I guess, first address why I just walked in late. So I do really apologize for my tardiness. I guess I was thinking as I was walking in here, feeling like super ashamed, that I always say in my practice that, you know, you really have to own your mistakes. And you guys, I just overslept. I haven't done that in like 10 years. I had a flight from Calgary this morning, was up all night and then overslept. So feel super ashamed, but I do think it's kind of an opportunity, like, to just internally be like, I'm doing too much. And
but thank you for agreeing to be on this panel
so
after a red-eye flight.
Like
yeah, that's probably
reflect
my fault.
on that. Maybe that's part of burnout. And B, just that I have always told myself that the best moments are when I make the mistakes and then own it, and then somehow my patient relationships like just flourish if I do that. So I hate making mistakes, but here I am, and I do apologize. I know it's disrespectful to be so late. So let's start again. So I work on a van. We're so privileged to have this beautiful van that's like a clinic. So I can bring this clinic to people all over HRM. So we go to soup houses, soup kitchens, we go to shelters, we go to parking lots, we go to all the encampments. We roll up, and our aim is to provide primary health care like you would in a doctor's office, right there. And I guess that's one of the ways we increase engagement to those who wouldn't otherwise be able to access primary care. And I do think that our system was built for a subset of people who live life in a certain way. And, you know, I don't even know if it works for them, but it does work for a certain amount. Then there's this other population that live life in a different way, and we have to acknowledge it. And so the system doesn't work for that kind of lifestyle. And so we have to completely shake it up and change it to address that person in that lifestyle. And so, in practicing medicine in that way, it feels really yucky and wrong because we're not practicing medicine in the same way that we would in tertiary healthcare. Therefore, it feels like I'm breaking all the rules all the time. But if I didn't break the rules, I wouldn't provide the care in the way that that lifestyle needs. Do you know what I mean? What was the question?
You've answered it well, even if you didn't know what it was.
Okay, great.
So we'll go back to Duncan. So the question that we were discussing when you were able to join us, and thank you for coming after a red-eye flight and taking on too much and being here, was everybody's teams and services and programs offer a wide variety of services, different practices. How do you decide what you are able to offer, identifying and meeting community need, and then are there barriers, whether they're resource or political, to offering more or doing more?
Yeah, and you have nothing to be ashamed of. I can tell you, I talk about MOSH all the time, and I have great envy for the resources you have and proud of the work you do.
The resources, I acknowledge it.
Yeah. So in terms of barriers, I'd say there's probably two things that come to mind. So first of all, I would say it's policies, I think, are a barrier for me. So again, one of the hats that I wear working in the inpatient setting, if policies are not written well or not written at all, then it's a huge barrier. I find that in this world, there are two types of people. There are those who understand the letter of the law and those who understand the spirit of the law. And more, I feel like it's the letter of the law and that trumps everything. So if policies aren't written well or written down at all, then it's a huge barrier. I'll give you an example. We had a young gentleman who has given me permission to describe his story and talk about him, but I won't name names. But he had been in Calgary living homeless and injecting on the streets and developed a spinal abscess, some partial, lost some function in his legs. He was seen by the addiction medicine team in Calgary, and very long story, much shorter. Ultimately, even in an atypical fashion, what they would not normally do in Calgary for his pain management and for his opioid use, they opted to give him injection grade hydromorphone to draw up and inject himself in his hospital room with some oversight. And it worked really well. He stayed in hospital in Calgary. He got the care he needed, but ultimately he got to a point where it was time to come back home to St. John. And so they had reached out to us to say, will you repatriate this guy? And we were happy to do so. So we brought him back to St. John. He arrived and we continued on with the management plan that was working really well for him. So we got to the point where we continued to do this, to provide him injectable hydromorphone. He was using it in his room, injecting himself. And we got to the point where we started to talk about a discharge plan, which meant some sort of safe injection site that doesn't exist in St. John. So as we started to look at a discharge plan, we talked to some, our chief of staff who went to administration. And when the administration heard what we were doing, they said, not only will there not be safe injection as part of a discharge plan, but what you're doing in hospital right now will stop immediately because there's no policy to do this. And so that to me was a very good example of where policy can get in the way. People on the ground were comfortable, the individual was doing well, but yet we couldn't apply common sense and we couldn't do the right thing because of policy. So I find policy is a great barrier. Another barrier, it can be a facilitator or a barrier, but it's the team that you have around you, the team that you have working with you, and the resources. So resources, when they're good, can be a great facilitator, but when you lack the resources, it's a great barrier. Along the line of human resources, one of the things that I've seen, I've been involved in this work since about 2008 or so, and some of the teams that I've worked with, over time, there's going to be some people joining the team, some people leaving the team, and for a variety of reasons, and that's just a natural ebb and flow. And sometimes when you don't have the right people, it can be a barrier. But I find that the approach to that, and it's, there are models of care, which I find are fantastic. But the models sometimes, I think you need to sort of look at, well, who's around, who makes up our current team, and how do we apply it? Yeah, so I like to talk to people, say, well, it's a bit like if you're playing hockey, and you've got, 5 goaltenders and no forwards, you're not going to have a very good team. On the other hand, even if you've got 5 really good goaltenders, on the other hand, if you have, a team that is really strong on defense, you're going to adjust your game. Or one team that you're playing one day, you may mix up how you're doing things. And it's a little bit like you can have models of care, but I think you need to adjust them sometimes to say, okay, what are our strengths? Who do we have around us? What game are we playing today? And sort of move and adjust. So I think the team that you have will ebb and flow, and you need to be able to adjust. And it can be a barrier sometimes, but I think if you think things through, your team is always a facilitator too.
Awesome, thanks, Duncan. Jack, do you want to take that one? We heard from Angele and Marty about this question already.
Oh, okay. Sorry. Well, I guess you're going to hear from me a lot, aren't you? So I can't second that enough. I think that's so key, and we don't talk about it at all. I think we build this general model that we're supposed to work within, and then we place all of these people who are unique characters. This work brings characters, doesn't it? You can't work here unless you're not like a character weirdo, right? And so within that, we have like pretty extreme positives and negatives. And that's just a characteristic of humanity. But I think that is what has been one of our successes over the 15 years, is that because we are so well resourced now, which is, it's embarrassing also. But we weren't. For 10 years, I worked out of a tiny little van, like a Sonera, Toyota Sonera. That's why my back's the way it is. But, you can do the work. But what we did was, because we're a small group and we're not part of the Nova Scotia Health, we were able to put people in, like, say I was really good at doing things in the moment, kind of Band-Aid approaching, and someone else is really good at details. So they throw me out on outreach to go run around like a chicken with my head cut off, and my colleague is doing like the detailed planning of a flu shot day and all of that. So play to your strengths and weaknesses just like you would. I think also just the basics of what you do, just don't forget the basics of the relationship, right? How you treat people. And to do that, you have to do your own work. I sound like a spiritual leader today, but I just woke up, guys.
We're with you, Jack. Don't worry, we're with you.
But I do think it's so important. Like, you have to check yourself and show up to your work in a way that forgets all of what other people think, and treat someone just like you would your brother or your sister or your friend. And that alone will do so much more medicine than anything else. And then obviously the little things like giving out bus tickets and phones, right? I can't believe what a currency phones are now. Getting people boost and linking up. And I also think one of the ways that you need to engage with the community is forget all the hierarchy of power and make relationships with all of the community people that are doing the work every freaking day. They're the ones that have the relationships with the clients. They're the ones that can get anything done. So make friends with the leader of the food bank, the ED of your local hardware store. Wherever these people go, you need to be working with the people who work there, right? And that's how you connect, but also you help fuel the community. It's also your responsibility in whatever role you are, in whatever level you are, to mentor the people around you, to make sure that you check in on people when they look like they're not quite right, when they're not doing well, and also share your own little piece of knowledge. I think we are waiting, including myself, for a long time. I just thought, oh, well, the people who are around me have worked. Like, I'm just like a baby in this. I don't know anything. I don't want to intrude on anyone or give my opinion. But, you have lots of helpful tips and tricks at whatever level you're at. And so it is your responsibility to share that in your own way, and to use the level of power you have in any way to affect change on people who aren't doing this work, to share your stories, because emotion is what moves people into action. And I think it's very easy for people at the top in policy-making positions to make huge decisions that impact thousands of people if they're not hearing the stories that make them feel like yucky, you know? So share the stories, and that'll help.
That's awesome.
Oh, yada, yada, yada.
No, that's awesome, Jack. And I appreciate so much what you're saying about connecting with and learning from the people who are already on the ground doing the work, who have those relationships. Morty, you might not remember this, but Morty and I have done a bunch of education sessions together, and the idea of hard to reach people comes up, and Katie talked about this in her talk before, reframing that as hard to reach doctors and hard to reach clinics. And I've heard Morty say, well, they're not hard to reach for me. They're my friends and my clients, and I work with them every day. They might be hard to reach for you, but not for me. So I appreciate that, Leah, learning from the people who are already doing the work and have the relationships. So we're at a research network conference, and I'm wondering if you all could share how your teams and programs and services have engaged with research, scientific evidence, program evaluation. Have you participated in research studies? Do you use research in your work or use scientific evidence in your work?
Well, definitely. I mean, harm reduction itself is evidence-based, so like all of our work, basically, well, I mean, not all of our work. If I say hello and good morning, I don't know if that's evidence-based. Well, I'm sure there's some evidence on it, right? But,
Someone's done a study.
yeah, somebody's done a study on how somebody feels when you say good morning, I'm sure. But, you know, like, the vast majority of our work is evidence-based, but we do, you know, partake in some studies. Like, there's 2 posters out there that we've helped work on along with Dr. Brothers. For example, like the quote-unquote hard to reach people. I mean, if you go to a community agency like Mainline, like a lot of the community trusts us, and it's a community that's hard to gain trust, you know? You know, so we can have that session and talk about what's needed and what the issues are, and you know, have it in a way where people are comfortable sharing their thoughts and their feelings and their emotions and experiences, where if it was a room full of mostly academics, you know, they might not feel comfortable doing that, right? So you have to go where it works, right? And often that's kind of our role in research, is like being where research can work, being where you can access the, you know, the people you need involved in the research. So that's definitely one way for sure. But like with all services in general, it just goes to treating people like a human being. And I know that sounds very baseline and blah, 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 but like, I know a lot of times where I've accessed healthcare in my life, I don't feel like I was treated like a human being. And, you know, that's not an uncommon experience. You know, it's very common, right? Most people I know who are injection drug users or people who are living on the streets, they've had horrible experiences in healthcare. It's the majority of people I speak to, so. Sorry for taking it on another route.
No, it's all good, Marty. Thank you.
Yeah, so I mean, big fans of evidence-based decision-making, and it's really hard to make informed decisions when research isn't there. So certainly always engaged with what's happening or trying to stay up to date with what's happening. And at the same time, as most under-resourced community-based organizations, it gets challenging to stay on top of what's happening. So I think, you know, opportunities like this, opportunities for collaboration between community-based NGOs or community groups, I think there's a real opportunity to shortcut the time lag between research and practice when we're able to work together in partnership. So we've been fortunate as an organization to work with CRISM on a few things. I think one of the first things that we were working on when I started with Peers Alliance was the co-study, if I'm not mistaken. I know CRISM was, the work that CRISM was doing was super helpful during COVID when trying to talk to like my board of directors around safety protocols and best practices and what was happening across the country and how we could work to keep community members safe and keep staff safe while at the same time not completely shuttering or shutting down services. Yeah, so I think research is hugely important. I think the other element is that the politicization of public health or harm reduction services can be more challenging when there is strong bodies of empirical evidence that support contrary perspectives or opinions. So I think all of that is important. And did I answer all the questions?
Yeah, great answer so far, everyone. Yeah.
Great. Yeah, I would agree that most harm reduction work that we're doing is evidence-based. So I think that we're doing it, we're living it, we're working within it. But beyond that, certainly with the clinic that I mentioned, the RECAP, the R actually is for research. So RECAP stands for research, education, and clinical care of at-risk populations. And so research was embedded right in the clinic model from the beginning. For many reasons. Certainly, I think it's important to try to make sure that what you're doing works. It's important to reflect on the work that's being done. And every community and every situation is going to have some unique things about it. So being able to monitor and track what we were doing, I think helped us to ensure that we were offering the most optimal care. It also helped us keep the doors open. Funding was an avenue for funding. And we were a not-for-profit clinic. We weren't getting funding from the government or the health authority, so we needed some means of keeping the doors open and paying people who were working for us so that they could also sustain themselves. So certainly very, very important in those respects. In terms of some of the frontline work that we were doing through research, we were able to access state-of-the-art treatments with regards to hepatitis C. We were able to access, direct-acting antiviral, interferon-free treatments before they were even available. So, it's helped us to keep on the forefront of things. One of the big projects that we did from day one and ongoing was a database that we called the HERE database. Another acronym, I can't even tell you what it stands for now. But it doesn't matter, it worked well. But one of the things that really struck me about that, the idea really was just to track some demographic and clinical information on the individuals that we were working with. And again, make sure we understood what was happening and that what we were doing was having good positive benefits and making sure we weren't having negative impact. But one of the things that really struck me was when we would ask people if they wanted to take part in this HERE database, and basically they would just, sign a consent form, and they understood that we would use information, it would be non-nominal, they could drop out at any point in time if they wanted to. But almost across the board, people would ask, is this going to help other people? And when they heard that it would have benefits for other people, they were like, absolutely happy to take part. And it helped me to remember how kind people are. Because a lot of times in the day-to-day work that we do and in this world that we live in, we are hit by the negativity, we are hit by the polarizing things. But the kindness of the people that we work with on the ground really stuck with me. And that's one of the big things I found where research impacted us.
I know we're on a time crunch, so I'll be really
No, we're good.
quick.
We're good. I got my eye on the clock.
Okay.
That's my job. Don't worry about that.
Okay.
You're good.
That's so great. I think also it gives people purpose, right? And I think through all the years, we thought that housing was the first point of Maslow's hierarchy, but we say amongst our team that actually giving someone purpose is probably the first one. You need drive and motivation to get anywhere. So it makes people feel like they are helping. That's great. I guess I would, in MOSH and the North End Clinic, I think we're getting better at using, at being involved in research, but I think we've done a really poor job over the last 15 years. Duncan's driven the research, and I'm really in awe of how they do it, because when you're just on the ground doing the work, it's easy to make that priority. But research drives policy. Research allows the people who are making the decisions and shuffling the money around to feel comfortable putting money into these progressive, crazy ideas that you're doing. So if you can give them the numbers and the objective data, you're much more likely to be able to do the crazy work you want to do that's quote unquote different or whatever. So actually I'd flip the question on you guys. You guys are in the room probably most involved in research, so please approach Mosh. Tell me how to do it, because that is my negative. I don't do that enough, but Tommy's done great work in our community doing the research for us. We have been, of course, involved in collecting stats of how many people we see. We've been involved in point of care testing and Hep C research. But I do think we need to figure out a way to do it more. So one thing I was going to say, sorry, is that people like me run around looking really busy. And, you know, I'm not great at responding to my emails. And I'm just like, go, go, go. And I think people come up to me and, is now a good time? And my response is usually, there's never a better time than this. So I think people who are busy are hard to approach sometimes. So it's not that we don't want to talk to you. So please, especially with me, just keep approaching and keep asking. There's never a better time to ask. And I think with research, it doesn't seem like priority in the moment when you're working with someone who's suicidal or something. So you just have to push yourself in, feel okay to do that, you know? So keep emailing and asking to do that work, especially if anyone has studies that they feel like the MOSH population could help with, please approach us, yeah.
Awesome, thanks, Jack. And I'll just have one more question for you guys before we open it up. And what you were just sharing there, Jack, is awesome. And wondering if folks have advice for the researchers in the audience for partnering with your community organizations, making those connections, especially with those research ideas in mind where, you know, research shouldn't have to be extractive or just going away for scientific merit, but actually addressing the priorities of your communities and your programs. Any advice for researchers out there on the best ways to work with you besides, you know, persistence and when there is an interest in it and there is a need, but connecting with you to figure out what are the priorities that you could work on together or how to make that happen, what resources would be needed, all those kinds of things?
I would just say really quickly, I think make it applicable. And in order to move forward, it's about relationships, as was mentioned earlier. I think those relationships, just continue to build them. And I think those are the two of the key things for research.
Yeah, I think relevance and a reciprocal exchange. So recognizing that it's not just about generating knowledge from other people, but there is opportunities for knowledge to transfer both ways. So be open to learning from the communities that you're working with or the partners that you're working with in the same way that you would hope that they would take up the knowledge or information that will be generated through the actual research project. I think focusing on ways that there can, you know, immediate impacts as well as long-term impacts. So just the simple things that we were hearing about for folks who were here last night, things like for the photo voice project, making sure that the participants could keep the cameras. And so there's an immediate benefit to the folks that are participating. I think those things can be important as well. Just so, you know, folks want to feel like they have purpose. Folks are absolutely motivated to help other people in their community. I haven't, you know, some of the folks that we see come through the door, they would give you the shirt off their back, and I've watched some of them do that. So I think there's that, but then recognizing that there's, you know, what else can we do to make people's lives just a little bit easier to show that we are valuing people as real humans and not just research subjects.
I think giving people an incentive is huge, you know, even if that's something as small as a meal, you know, some kind of incentive in doing it. And if that's helping somebody, that's often a huge incentive. But also like meaningfully engage people with lived or living experience. I find oftentimes in general, it's just as a tick on a box instead of actually like making sure it's meaningful. And recognizing that, like, you know, I have lived experience, but I don't necessarily speak for every person with lived experience, right? I, you know, guarantee I have some different opinions than, you know, Katie probably has, and vice versa, right? Like, we're both our own individuals. So, like, there's that saying, like, nothing about us without us, but then adding on to, you know, more than one of us in the room as well, right? So I think that's very helpful. And then, like, as I mentioned earlier, like, if you are having trouble doing that, reaching out to a community organization like Mainline, like even Mosh, right? Mosh does a lot of great work. I hate going to the hospital. I'd rather go to Mosh. You know, people trust the agencies. They don't necessarily trust some researcher in a suit, you know?
For sure.
No offense, but you look like the person who yelled, "Get a job" at me. Like, you know, like, you know,
Or I've been called narc.
yeah.
I've been asked if I'm a cop before.
Yeah.
I had to stop wearing polo shirts.
Yeah, polo shirts are a no-go. Yeah. And try buying drugs wearing a polo shirt. Yeah, it's not very good. You're better off shirtless, honestly. Yeah, but, you know, meaningfully engage people. And also, you know, if you're noticing you're having a hard time getting engagement, examine yourself, you know. Recognize, you know, we're not perfect. There might be a reason nobody wants to engage in our research project. Maybe we have too many barriers. You know, maybe it's too difficult for people to reach out. Maybe they just don't know about it. I mean, if your only way people are knowing about it is through Twitter or Facebook, when the majority of people, like, sleeping rough don't have a cell phone, and you're trying to do a research on people sleeping rough, good luck engaging with them that way. You know, you got to figure out how to actually get the research and get the to engage with the people you're trying to have involved, I guess. I don't know if I overtalked there.
No, that was awesome, Marty. Thank you. Do you have something to add there, Jack?
Yeah, of course.
That's why you're here.
That's why I'm here. I think two things. One thing, I can't second all of that enough. Two, I've heard so many from our clients that they never hear the outcomes of the research. So just like you have to tailor the research to get the information from this population, it is our responsibility to figure out how to relay the information back to that population in a different way than you would to a conference or policymakers. So it's really friendly and kind to put a few tidbits, summary points of your research into a letter and distribute it amongst us and print it off for us. And so, because if you think about sleeping rough or living in chaos, you become down, you reduce your life to very basic needs, right? Kind of like when you go camping, it's all about building the fire, making the food, all of these things, right? So when you think about addressing that population, you need to make things really basic. Now, that doesn't mean that we can't make fancy research out of it, but you do have to ask the questions in that way. And my other point is completely gone.
Cool.
I guess that's all for today.
Yeah. Is there time for questions? Still a few minutes? Yeah. Anybody have questions?
Oh.
Sure. For the panel on anything that we talked about or else? Anything else? Did we steal is this the microphone that comes from the crowd?
We got a runner.
Thanks, guys. Thanks, everyone. Thanks.
All right. So nice to have a mic brought to me instead. I'm just curious, well, maybe two questions, but you can pick and choose. When you were talking, sort of the theme was about wraparound services, and I guess I'm just curious, what from maybe respectively from different organizations, what is the biggest missing piece of those that is needed for each organization that you might identify, or what do you see as the missing piece? And then I had a separate question about research, which is, do people actually, like, I also think does each organization have their own research priorities and questions that you are dying to know the answer to, and you know, can the community work to help provide those answers for you rather than the other way around, I guess. So.
What a great research brain. That's a great way to phase it and ask it, and I will contemplate that and get back to you. But I think one of the things that we're missing here in Halifax for sure is the link between all of the work happening at the hospital and then all of the actual wraparound the agencies around here are doing incredible work, beautiful work happening in the community. But it's not, I don't feel like it's respected at the hospital in a lot of ways. Now, we have come light years. It's beautiful how far we have come, but we still need to make that connection. So I think there is room for some evidence between how to connect with agencies that are not medical in the community and how that reflectively improves patient care, you know, how important those little agencies are, like food banks and furniture banks and housing projects and all of those kind of things. I'll pass it on to you.
Thank you. Yeah, so I think like for question one, like part of our challenge with outreach work is trying to identify sort of like where is the next rung up, and we're as much as we work to try and support with service navigation, a lot of the folks that are really struggling with what does next steps look like are folks who are dealing with service restrictions from various services. It's not immediately apparent where we can help connect people to more meaningful support. So for outreach services, we're really focusing on survival needs like sleeping bags, hand warmers, but the solution is folks need to be sheltered and housed. So it's, how do we continue to develop a continuum of care so that we're effectively able to move folks through it, because right now we're not. So that, that for me is a big part of question one. And I think where we have had some of the best work happen is where service providers from different agencies or from different government departments are able to sit at a table and engage a participant in some support planning. And that support plan isn't contingent on participation in any particular program or isn't contingent on where the person is staying. It's a plan for them. And I think far too often, at least locally in PEI, things may be slightly different over here, is we have a whole lot of services that are sort of siloed within themselves. And so, case management support might be handled over here. And if that person's not at that program anymore, they no longer have access to that support. And so how do we meaningfully wrap supports around individuals rather than sort of having services attached to particular agencies or departments? I think that's another question that I would like help thinking through for sure. And I think would have significant impacts on the folks that we're working with. I think like in terms of research areas, like we're keenly paying attention to work that's happening around replacement therapies for stimulant consumption. So that's something that we're paying attention to and are encouraged by, and will be work to share that information with participants as well. And then I think there's also like and maybe I'm sure like an overdose prevention site or a safer consumption service may be sexier for local government if it was attached to a research project, but it's not. I personally do not have the capacity to try and figure out what that looks like while doing the bazillion other things that are on the go. So it's the structures and systems obviously that we're working in don't often make it easy, but as researchers in the room, your local harm reduction agencies are absolutely phenomenally busy, but they're also very keen to talk about making things better. And so if there's ways to collaborate with local harm reduction agencies, or if you're just, if this is an area that you're interested in, I would encourage you to go down and chat with folks about what they're seeing, where they see current challenges, or where they would see an opportunity for a research project.
Yeah, you go ahead.
So like some major barriers that I see are housing, of course, treatment options. I mean, people are talking about forced treatment. You can't even access treatment if you want it. So I don't know how that's going to work. Like there's a huge list of barriers. I mean, specifically detox. Don't get me wrong. There's people working there, working really hard, and I'm not talking bad about that. But to get into detox is incredibly difficult. You're waiting on a waiting period of a week, maybe longer. And, I had a friend who, had, multiple years abstinent, just had a baby girl. And then, he started using again. And then, he came to me, wanted to get in detox. Within that waiting period, he died. That was very preventable, if we had the beds and access there, And not just that, maybe if he had access to a safer supply, right? There's a lot of things that could have prevented that, right? Having safer supply there for people, in general, could have prevented that, So, I could talk about barriers, like that could be a whole panel, right? But there's a lot of clients who, a lot of their issues stem from housing. I know for myself, when I was in Fredericton, I used crystal meth because I was sleeping rough. I was too young to stay at the shelters. I don't have a place to sleep. Okay, I'm not going to sleep. Don't have food to eat. Okay, I don't have to eat. Meth was a survival tool for me. There was no way of fixing that without housing, right? And when there's no housing, or the only quote-unquote affordable housing is based on somebody's income that makes way, way more than someone with my income at the time, which was none. Affordable for who, right? But yeah, I don't know. There's a lot of barriers, but there are some success stories even within those barriers. Obviously no identifying details, but a client of ours was coming in very psychotic, very angry, kind of aggressive, not kind of, just flat out aggressive, but banned from everywhere, but we were just willing to listen to him, and through listening and being patient and filling out applications, we were able to get him housed, and his mental health got a shit ton better, So just housing first can be huge, but also purpose, One of the things we do at Mainline is the peer walk. Usually it's only a shift once a month, but, you would go out with our lead peer and walk around community and serve the community, right? Whether that's harm reduction supplies, whether that's a conversation, whether that's an naloxone kit. And I know for me, that's how I started at Mainline, was through the peer walk. And I found it gave me a sense of purpose. Don't get me wrong, I've done some harm in my life, and to be doing something good felt good, Yeah. And when all of society's telling you you're a piece of shit, having something that you can feel good about can be very helpful, I don't know, I went off topic.
No, it's another great answer, Morty. Thank you.
I would just say thanks for those comments. It's bang on, really. Yeah. With regards to wraparound services, I think, again, using the metaphor from earlier, medicine is a team sport, and I think that you really need the full complement. There's been times when we've maybe had a nurse practitioner and an RN, but no social worker. Big gap. If you don't have somebody to provide the primary care piece, massive gap. So I think, again, you really need that full complement of individuals and human resources. With regards to research goals currently, I'm so excited to hear more from Sarah Davidson about the stimulant replacement therapy. That's such a challenge right now. Just helping to manage is incredibly frustrating for everybody, especially the individual struggling with the stimulant use. In terms of the homelessness piece and that connecting the hospital to the community, we're just embarking on a convalescent housing strategy in St. John, where individuals who don't have a place to go for part of their discharge, but yet require some ongoing treatment, we're just moving into that. which we're really excited about. The other thing that I'll just mention as a last point that I'm excited about too is bringing ceremony and spirituality back into the community. So we're working really hard to impress upon people we need something like Mosh in St. John, and it's being driven by the Monaquask Wellness Circle, which is our St. John Indigenous Health Advisory Circle, and they see it as an opportunity to bring ceremony and traditional teachings into the community and combine it with more sort of Western eye healing with, wound care, bloodborne pathogen screening, that sort of thing. So we're excited about that as well.
Just quickly, I think it's really important to, there's a term in research right now called task shifting. I think it was has anyone heard of it? Task shifting? Okay, so in Europe, someone created it. It's a great way of saying, like, we have so many barriers in providing the care because we're not allowed to allow that person to do a certain task, which they're completely capable of, and there's all kinds of reasons why we don't do that. But we should be finding a lot of. I think when I think about 5 years from now, the work that I'm kind of starting to do more and more is mentoring and teaching others how to do this work. And so I think, really quickly, I think that there's some room to, there's no textbook on how to do outreach, primary care or outreach, period. And it's a huge learning curve. And so teaching and mentoring others in that role is huge, and there's no research on that. And also in the task shifting, proving how it works, to have a peer do a medical test or procedure even. I think we got room to push.
Awesome. Thanks, everybody. And that's time, eh? Yeah, thanks, everybody on the panel so much.